The management of HMA failure, it's in this moment, it's quite difficult. We do not have agents that have shown an extremely high efficacy and activity. Also because not many have been experimented in MDS. One drug that I forgot to mention in the new approach to first-line treatment in MDS is magrolimab, is an anti-CD47 antibody that obtains results in terms of overall response rate in a very high proportion of MDS high-risk patients. Now, this is a drug that I would like to see used in second line, as well as the other agents I already mentioned. Unfortunately, as I mentioned, we do not have this choice at present. And my attitude is to add venetoclax to the patients who lose response to hypomethylating agents. But first of all, I would like to remind that the patients who lose response should be reevaluated completely. This means not only perform bone marrow aspiration or biopsy, but also reevaluate by NGS the presence and the variant allele frequency of the somatic mutation. Some new somatic mutation may have appeared during the loss of response to hypomethylating agents, and it is important to check it because they could be actionable and they could be subject to respond to specific target therapy, like, as I just mentioned, the rare but present IDH1 and IDH2 mutations, and also TP53. So venetoclax is very active. 41% of patients who received some cycles of venetoclax plus azacitidine responded. This percentage is more than 80% if the patients could keep the cycles and the treatment for more than 6 cycles. So I think that if we may indeed balance the dose and the duration of venetoclax in this frail subgroup of patients, we could indeed prolong their survival. I just have to remind you that the survival is around 5 months, and the addition of venetoclax, as shown recently, has prolonged survival up to 1 year and longer. So I think this is something we should really keep in mind. Patients will respond. The patients responding a little bit less are the ones who have TP50 mutation. In these cases, I would suggest you to think and rethink to the eligibility of these patients to transplant, because once again, this is a curative approach that we should never forget to evaluate for all our patients.